He's a physician scientist, and he does clinical research focused on improving the symptoms experienced by patients treated with dialysis. For attending this webinar, one continuing education credit is available to all nurse and social work attendees who've pre-registered and who attend today's event, including filling out the evaluation form at the end. For those of you who are only joining by phone, please send your phone number to Heather Cecile at hcecil@nw5.esrd.net. Again, that's hcecil@nw5.esrd.net, so that Heather can verify your attendance for the CE credits. The CE credit forms are going to be emailed to each attendee, and this will be done within 1 month of the event, and the certificates will be emailed to the email address that you provided during registration. Finally, please post any questions that you have during the presentation using the Q&A icon at the bottom of your screen, and we'll try to answer as many questions as possible at the end of the presentation. Dr. Mehrotra, please, the floor is yours.
May, thank you. Thanks to all of you for making the time to hear about our work. So the title of my presentation is Depression in Patients Undergoing Dialysis. I want to begin by providing the context for why I think this is important. Just a moment. I've been taking care of people undergoing dialysis now for 20 years. And I think it's fair to acknowledge that the plate of people with kidney failure is full. Most people have other health problems such as diabetes, high blood pressure, heart problems. So kidney failure is not the only problem that they have. They have many other problems. Many are legally blind or have had an amputation or are functionally dependent on others. They are admitted to the hospital about twice every year, and on average spend 12 days every year in the hospital. And people that are admitted to the hospital and are discharged, 30%, about 30% nationwide, are readmitted within 30 days. So people have numerous transitions in care, and I think it's fair to say that neither the patients nor the healthcare system, in the silos that we have for the care we provide, handles these transitions very well. Not surprisingly, many patients report a low quality of life. The treatments that we have for kidney failure also ask a lot from our patients. In-center hemodialysis, the patients have to commit to come to a dialysis unit 3 times a week. 3 to 4 hour treatments require 4 to 5 hours of commitment. PD treatments have to be every day. Home hemodialysis, it's 5 to 7 times a week. And a lot of people that have done research in this area think that even this amount of dialysis is not enough and we need to give more dialysis. There's no chronic disease, the treatment of which requires so much from patients over so long a period of time. And I say that I've reflected on this many times over the years. Week after week, month after month, year after year, we are asking our patients to do a lot just to be alive. And then there are limitations on diet. We tell people you cannot have much salt, you cannot take too much potassium or phosphorus or fluids, but you need to eat a high protein diet. And the amount of medications that we are prescribing to our patients is very large. If you look at a study that we did from 3 sites in the country, a person on dialysis on average is asked to take 19 pills in a day. 50% of them are phosphorus binders, and 50% of them are other pills. So this is on top of the demands on their time for dialysis, as well as the restrictions on their diet. It's hard enough. And if you add to the mix, there is a high prevalence of mental health disorders that is experienced by people on dialysis. And it includes anxiety, post-traumatic stress disorder, and depression. And I just want to spend like 2 minutes talking about PTSD before I go on to depression. So this is a very nice study that was done from Germany. As you can see, this was published now 12 years ago, in which the investigators administered survey to people that were starting dialysis and asked them about their emotions and feelings that were related to from the need for dialysis. And I will start at the left and then end on the right. There is the issue, people are concerned about danger to their life. They have a large proportion of them express helplessness, and they are afraid. But what particularly caught my attention is that about 10% of people reported to have post-traumatic stress disorder that is related to dialysis. I interpret that in several different ways. What one could be is that there is a major organ has stopped functioning, and people are afraid of their own mortality. And then there are events that are outside their control, when their access to dialysis may be limited or restricted. A classic example is something that was in the news some years ago, was Hurricane Katrina. And we have hurricanes, we have earthquakes, we have snowstorms that make it challenging for people to come to dialysis. People took advantage of the experience with Hurricane Katrina to try to catalog how people on dialysis responded. And as you can see, almost 1 out of 5, 19% of people had both PTSD and depression. Over a quarter of patients had depression alone without PTSD, and 5% of patients had PTSD alone. So 19 plus 5 is 24. 1 out of every 4 patients that lived through Hurricane Katrina experienced PTSD. And of course, Hurricane Katrina was an extreme example. It is something that we have to be mindful of when patients feel that they're not able to get to their dialysis treatments for events that are beyond their control. It takes an emotional toll on our patients. In some, it is so severe and extreme as to qualify as PTSD. Recall the 10% I showed you from the study in Germany was without a natural disaster. And this is with a natural disaster that gets amplified. So we just have to be sensitive and mindful of that. So we'll go to this poll question. You can respond. What percentage of dialysis patients suffer from depression? I don't know if you can see the answer to the question. I'm not able to see it on my screen. Oh, there you are. So 47% people said 30%, 45% said 60%. The correct answer is 30%. This is a collection of all studies that have looked at how many patients at any given point in time have significant depressive symptoms. These are studies from around the world, almost 200 studies that included over 45,000 people, in where the depressive symptoms were assessed by several different ways. It didn't matter how it was assessed. When synthesizing all of the data, 37% of people had significant depressive symptoms at any point in time. So just put it very simply, it's fair for us to assume that at any time point, 1 out of every 3 persons on dialysis has depression, has depressive symptoms, and I'll get back to the issue of depression. So let's go to the second poll question. What's the difference between depression and sadness? Depression is a disease, while sadness is a normal emotional state in humans. Sadness is short-lived, but depression is persistent and long-term. There are many types of depression, while sadness is something normal and specific to recent circumstances or events. All of the above. All right, so 93% of you selected all of the above, and that's correct. So depression is a disease, while sadness is a normal emotional state. Sadness is short-lived, depression is persistent and long-term. There are many types of depression, while sadness is something normal and specific to recent circumstances or events. We're just gonna go on. So in terms of the diagnosis of depression, an overarching summary of what is depression versus, say, sadness is depressed mood or loss of interest or pleasure in daily activities for more than 2 weeks. I just have underlined the fact that the symptoms have to be present for more than 2 weeks for it to qualify as what we call as a major depressive disorder. The mood has to represent a change from a person's baseline. And it results in impaired function. And that impaired function could be in any domain. It could be in social, occupational, or educational. And there could be other ways in which it would manifest an impaired function. So loss of interest, a low mood essentially for 2 or more weeks. That low mood is not usual for that person. This is something new and different. And it is interfering in a person's ability to live the lives they want to live. It's interfering in resulting in impairment in function. So these are 3 important things to consider as we are talking to patients to determine whether or not they have depression. Let's go on to this third poll question. Is grief and loss related to treating dialysis patients a permanent or temporary part of depression? So grief is a feeling of sadness, numbness, and/or anger that follows a major loss. Loss of a loved one, receiving a diagnosis of end-stage renal disease, loss of a job, or demise of a relationship can lead to grief. Grief and mourning are normal reactions to losing something or someone important. Although grief and loss can trigger major depression, the 2 mental health conditions do not exactly have the same symptoms and involve different therapeutic approaches. You can select more than one of the following. So it's not just that only one answer is correct. All right, so 53% of you selected D, so which is right. So let's just move on. The next poll question is symptoms and signs of depression include always feeling sad, loss of interest, changes in appetite, trouble sleeping, loss of energy, feeling worthless, difficulty thinking, thoughts of death or suicide. So you can select any number of them. Okay, so each one of them is correct. So some of you didn't select some of them, but most of you did select most of them, so that's right. So let me just go on. I started off by saying, by identifying that there are three components in making the diagnosis of depression. First, that the symptoms have to be present for 2 or more weeks. It has to represent a change from baseline and has to result in impaired function in any domain. If you go on then to the psychiatric diagnosis of major depressive disorder, I just want to identify for you the 9 symptoms that qualify for a diagnosis of depression. And the reason why I do that is to point out to you that some of them overlap with symptoms of kidney failure. And that makes it difficult for us to make a diagnosis of depression. So I already talked about depressed mood or being irritable, decreased interest or pleasure, significant weight change or change in appetite. Just focus on that for a moment. That is common in people on dialysis. Change in sleep, whether it is they're not sleeping enough or they're sleeping too much. Change in activity, fatigue or loss of energy, extremely common in people on dialysis. Guilt or worthlessness, concentration, they're not able to concentrate, and suicidality. So if these 9 of them, at least 3 of them overlap significantly with the symptoms of kidney failure. Significant weight change or change in appetite, change in sleep, fatigue or loss of energy. And that makes the diagnosis of depression in people on dialysis hard. What is important also to understand is that depression does not just go away. So it is, we started off by making a distinction between sadness and depression. Depression is a disease. This is a study that was done out of Pittsburgh at the VA. And what they did was they gave a questionnaire for depressive symptoms to all the patients every month. And these lines represent where the depressive symptoms were in individuals over, say, a year or 2 years. And the important point here is that there are people, for example, this group 1, which is 15% of the people, they didn't have much depressive symptoms to begin with. And over time, they didn't have depressive symptoms over time. Compare that to group 4 or group 5. That's 13% or 12%. There's some fluctuation in the severity of depressive symptoms, but overall, these people generally remained depressed over time. So the notion that depression is transient, that it would go away, it is in response to people's circumstances, is not correct. As you can see, people that are depressed remain depressed. And the point that I'm going to try to make later on is that they would benefit from treatment. One of the, I started off by saying is that we ask a lot from our patients. They have a high burden of disease, and the treatments that we have ask a lot of them. And when people are depressed, it makes it more difficult for them to do what it takes to take care of themselves. This is an old paper almost 20 years ago. It looked at studies on the effect of the presence of depression on people's ability to adhere to treatment recommendations, whether it is recommendations around dialysis, coming for dialysis, how long they need to dialyze, fluid intake between dialysis treatments, phosphorus intake between dialysis treatments, or taking their medications. People that have depression are much less likely to be able to do what we ask of them. And so it is not surprising in how I started off also by saying that depression affects an ability of an individual to function. In the context of kidney failure, functioning means being able to adhere to diet or dialysis or medications, and not surprisingly, people that are depressed are not able to do that. So what have I said so far? Just a quick recap before I go on, that many people on dialysis are depressed. Depression does not just go away, and depression makes it hard for patients to do all that they need to do to manage their kidney failure. So in the time that I have remaining, I'm going to point out to you that if depression is not treated, it leads to more problem with people's health. In people with kidney failure, I've kind of started off by making that point already, that depression can be difficult to diagnose. And depression is treatable and reduces suffering. Let's go on to the next poll question. Depression can affect which of the following? Patient functional status, patient quality of life, treatment adherence, decision-making about dialysis care, risk of hospitalization, mortality. All right, so all of these answers are correct, and many of you identified all of them. And I'll show you some of the studies that have been done to corroborate what we just asked. So let's start with the health consequences of depression. If any of you has had people around them, your loved ones with depression, what would be evident to you, hopefully, is that depression in and of itself causes considerable suffering. We don't have to know. It doesn't matter whether it results in greater hospitalizations or not. Depression should be treated because it makes a person feel miserable. And being miserable is no way of being. So I think depressive symptoms, I don't need anyone to tell me, oh, it doesn't change mortality. I don't care. If you've had people with depression around you, and you've seen people suffer, you know it needs treatment. But in people with kidney failure that are undergoing dialysis, the consequences are even greater. For example, there are a large number of studies, and this is just a listing of some of these studies that have shown that greater the severity of depressive symptoms, higher is the risk for death. And the reason for the higher risk for death very likely is the challenges people with depression have in doing what they need to do, showing up for dialysis, or cutting treatment short, or taking medications we ask of them. It just makes it harder. So people with depression have a higher risk for mortality. Depressed people are more likely to skip dialysis. Again, just reminding those of you that may have had people with depression around you, when somebody is depressed, it's challenging enough at times even to get out of bed. You just don't have the motivation to get out of bed. And it is not surprising that people that have depression are more likely to skip dialysis. And so, for example, this, I'm just pointing out to you, if you can see on my mouse on the screen, this middle panel is the severity of depressive symptoms. This is, on the left, is this low depressive symptoms. On right is more severe depressive symptoms. And on the top is the probability of missing dialysis sessions. People that are not depressed don't miss dialysis sessions. People that are depressed miss a lot of dialysis sessions. Conversely, if there are people in your unit that are missing dialysis, it would be important to make sure, rather it'd be easy for our healthcare staff to be frustrated and be upset with the patients who are not showing up. But one potential reason for people not showing up is that they could be depressed. And I think we have to approach people that are missing dialysis with sensitivity to determine whether or not they're depressed amongst those that are missing dialysis. Similarly, people that are cutting dialysis short. There's the same evidence in people that have greater severity of depressive symptoms are more likely to ask the staff to cut the dialysis treatment short. They just cannot stay tethered to the machine for the time it is taking for the treatment to finish, and they want to get off soon. So I would just urge you to be mindful of that relationship as we assess people that are missing dialysis or routinely asking for their treatments to be cut short. In people that are doing PD, people that have depression are more likely to get peritonitis. So here the measure of depression is this BDI, that is a score of greater than 11. Essentially, people that have depression have almost 3 times the higher risk of developing peritonitis than people that are not depressed. And this is, again, doing PD safely requires a series of steps that need to be done to make sure contamination does not happen. And it is in people that are depressed, they're just not able to keep that thing straight and are more likely to get contamination and get peritonitis. People that are depressed are more likely to go to the ER. So as we go from left to right, the bottom panel is showing the severity of depressive symptoms. It's going from low severity of depressive symptoms to high severity of depressive symptoms. And as you can see, there is a higher likelihood of people showing up in the ER, the more severe their depressive symptoms. Similarly, people that are depressed are more likely to be admitted to the hospital. So again, going from left to right is greater severity of depressive symptoms, and going from left to right is a greater probability of being admitted to the hospital. So I want to start off, I want to summarize this by saying, once again, low mood is suffering enough. I don't think that we need to rationalize treatment because of the associations with mortality or with peritonitis or hospitalizations. I personally feel very strongly that low mood is suffering enough, and that suffering, it's incumbent upon us to relieve that suffering. But if we also acknowledge how difficult it makes the life of a person with kidney failure, it results in higher mortality. These are people that are more likely to miss dialysis or shorten treatments, more likely to get peritonitis, have ED visits, or be hospitalized. It becomes even more important to make sure that we intervene to relieve that suffering. I've said this before, and I'll say it again, is that some of the symptoms of depression are the same as those from kidney failure, or they could be confused with side effects of many medicines people on dialysis need to take. It's difficulty sleeping, not having enough energy to get through the day, not feeling hungry. When that diagnosis is so difficult to be made clinically, one way to overcome that is to have people be screened for depression. And those of you that are working in the dialysis unit know that Medicare requires every dialysis unit to screen every patient for depression once a year. And facilities have to report if the screening test for depression was positive or negative or not done, and if positive, whether or not there's a plan for treatment. So many of you that are on the call may be the ones that are doing the certification for your unit and or administering the screening test, so that you're well aware of this requirement. And there has to be a plan for screening and develop a follow-up plan. Most dialysis units in the United States use the PHQ-2. And PHQ-2 has 2 questions. Over the last 2 weeks, how often have you been bothered by any of the following problems? Little interest or pleasure in doing things, feeling down, depressed, or hopeless. And that's on a scale of 0 to 3. So the maximum score would be 6, the minimum score would be 0. And a general approach for using results is that if the score on PHQ-2 is greater than 3, that is not enough to make a diagnosis of depression. It needs more assessment. And one way of doing more assessment is to do another test, the PHQ-9. And many units have a protocol such as this. And it has 9 questions on the scale of 0 to 3, range of 0 to 27. And if the score is 10 or higher, I would suggest that there be a trial of treatment. You can send them to a psychiatrist or a therapist. I think, and that's all right. If a patient can get to a therapist or a psychiatrist, that's all right. The concern that I have is that depression is so common in people on dialysis, and it is so difficult for people on dialysis to get to additional appointments, that I think that the responsibility for the treatment of depression has to be assumed by the nephrology care team. I think nephrology care team is hesitant or reluctant to accept that responsibility. I'm aware of that. But I think if we are to look out for our patients, there will be many people that are on dialysis whose depression treatment would need to be the responsibility of the nephrology care team, or those patients will never get treatment. So what more have I said? I've said depression in of itself causes suffering to the person. I hope that point has come out, at least my opinion has come out loud and clear. You may not agree to my opinion, but that hopefully my opinion has been clear. It adds to other health problems like skip dialysis, ED visits, hospitalizations, and peritonitis. It is hard to diagnose in people with kidney failure. It helps to use a test like PHQ-2, which is now done routinely at least once a year. And just underscoring the point that if we are not screening people regularly, most of the time depression is not diagnosed. I don't want to go into the complexity of this slide other than to say that in people that report that they're feeling downhearted and blue, only 17% of them were diagnosed in having depression by a physician in the medical records. So most people that are even expressing depressive symptoms are not recognized to be depressed. And even when people are recognized as having depressed, most of the time people are not treated. This is from a clinical trial. Again, I don't want to go into the complexities of what is on the slide, other than to say that 3 out of 4 people that were recognized in having depression did not get treatment. And this is, I believe, reflects the practice generally in the country, that most people that are on dialysis that have depression are not treated. So what are the options for treatment of depression? We think often of drugs, antidepressant drugs, and the drug class that is used most often is the selective serotonin receptor uptake inhibitors, like fluoxetine or sertraline or escitalopram. I'm just using the generic names for the drugs that are commonly used. There are different forms of psychotherapy. The most common and effective form of psychotherapy is cognitive behavioral therapy. But then there are other types of behavioral therapy that are listed other than cognitive behavioral therapy. And then there are complementary and alternative medicine, such as acupuncture, meditation, St. John's wort, yoga, and exercise. So let's go on to the next poll question. This may be the last poll question. What treatment options does your dialysis facility offer for patients with depression? Cognitive behavioral therapy, antidepressant medication, peer mentoring, support groups, other, none. All right, that's actually very reassuring that there are over 50% of you that have responded work in units where there is at least some treatment that is made available. Only 11% actually say there is no treatment available. So that's actually very reassuring. 89% of you essentially have selected one of the above. So it is cognitive behavioral therapy or antidepressant medication or peer mentoring or support groups or another form of treatment. So that's excellent. I find that very reassuring. All right, so let's go on. So yes, I've been arguing that depression needs to be treated, but I think it's important for me to also acknowledge that it is challenging to treat depression in people on hemodialysis. The first thing is that there remains a stigma with the diagnosis of depression. It's not unique to people on dialysis. It also is present in the general population. And so acceptance of the diagnosis of depression is challenging. There are not many studies that have been done to see what treatments work for people on dialysis. It's for that reason we did the study we did, and I'll be sharing the results of the study with you. There are unique challenges with each form of treatment in patients undergoing hemodialysis. For example, for behavioral therapy, cognitive behavioral therapy, it requires people to go to a therapist once a week for 8 to 10 weeks. And this is over and above the need to go to dialysis 3 times a week. And so it makes it very challenging. Forget about whether or not there's insurance coverage and or if there's a therapist available for people to engage with. And the drugs, I already told you that people on dialysis take on average 19 pills every day. And this will add to the number of pills. And there's a concern about side effects with medication. So what is the evidence? So, I mean, the important reason for recognizing these challenges is to make sure that we have evidence that these treatments work. They're worth the bother only if we can show that these treatments work. What if I have people go to a therapist once a week, or I have them take an antidepressant medicine, but they don't work in this patient population? That will be all effort for nothing. So this is a study that was done in Brazil. This was published now 10 years ago, in which what they did for people with depression is to have group therapy. So not one-on-one, but a group of people, group of patients with a therapist undertook cognitive behavioral therapy. What is important to note is that, like, you can look at any of these two graphs that are being shown. The bottom line is with treatment, and the top line is without treatment. Symptoms with depression seem to get better over time in both groups. But the increase was much greater and faster in people that were treated, right? So you can see that whether you're measuring it with BDI or you're looking at it with Mini, the depressive symptoms got better more, they got better more and faster. This is a study that was done in Brooklyn, again, in which this was a smaller study in which this was one-on-one therapy with a therapist, with the therapist coming to the dialysis unit to talk to the patients. So the patient is connected to the dialysis machine while they're doing dialysis is when they would have the therapy session. So essentially lowering the barrier to treatment by having the therapist go to the patient rather than the patient going to the therapist. And as you can see, these gray bars are the magnitude of improvement, and the white bars are without treatment. So as you can see, the gray bars are taller than the white bars, so the magnitude of improvement was greater with treatment than without treatment. So there are two studies that I've shown you. Compared to no treatment, cognitive behavioral therapy, whether given in a group setting or one-on-one, makes depressive symptoms better. What about antidepressant drug therapy? There are these 4 studies that have looked at this before we did our study, and essentially you can see 2 studies showed that symptoms got better and 2 studies showed symptoms did not get better. The challenge with these studies are that they didn't enroll too many people, and in people that were enrolled in the study, not many stayed on treatment. So this is not good quality evidence. You cannot say the drug doesn't work. What you can say is that from this, you don't know if the drugs work. So we decided to do the study we did. We called it Ascend. It was published earlier in the year, this year. It's a multi-center clinical trial of people undergoing hemodialysis, primarily to compare the efficacy of 12-week treatment with CBT and antidepressant drug therapy. It was conducted in 3 metropolitan areas: Albuquerque, New Mexico, Dallas, Texas, and Seattle in Washington, in 41 different dialysis units. In Seattle, we enrolled patients from Northwest Kidney Centers, Puget Sound Kidney Centers, Olympic Peninsula, and DaVita. The point of it is actually, the more important thing is that we enrolled from virtually every large dialysis provider in the country. We had people enrolled from DaVita units, from Fresenius units, from DCI units, and then from a whole host of nonprofits, small local nonprofits. We approached almost 3,000 people that were undergoing hemodialysis for at least 3 months. And we had them screened for depression. 90% of them, over 2,500, completed the screen, and we randomized 120 to treatment. So the study was in which half the people were treated with CBT, half the people were treated with drug. And the behavioral therapy, the CBT, was conducted in the dialysis unit by a therapist while the patient was undergoing hemodialysis. Now this was, I say it simply, but this was at every step of the way, we were challenged about that approach, primarily out of concern for privacy of individual patients, whether it was appropriate for a highly sensitive form of treatment to be delivered in a setting where others could overhear what was being said. We gave patients the choice to do it outside the dialysis unit. So we didn't force it on people. We said, you have the choice of doing it when you're doing dialysis, or we can do it at another time, another place. Virtually everybody selected to get the treatment when they were connected to the machine. Patients were willing to sacrifice their privacy for the convenience of getting treatment when they were doing dialysis. Drug therapy, we used sertraline, which is the trade name for that is Zoloft. That's a generic drug. A generic preparation is available. It is very inexpensive. And the reason why we selected sertraline was because we didn't want, once the study was completed, we didn't want cost to be a barrier to access to treatment. And we started at a low dose, and we made changes to the drug slowly based upon whether or not people had side effects and how they were doing with it. These are the results, essentially showing that depressive symptoms got better with both CBT and sertraline. The improvement in depressive symptoms was greater with sertraline, with the drug therapy. So as you can see, there was at least a 50% decrease in scores in 36% of people that were given CBT, 43% with sertraline. Now this may seem low. Essentially, I'm saying that 1/3 to 40% of people had significant improvement. But if you look at the efficacy studies with antidepressant drugs in the general population, when given a single agent, only about 60% of people get better. Yes, 40% is lower than 60%, but the comparator is it's not as if in the general population, 100% of people get better, and in dialysis, only 40% get better. The difference is more like 60% of people get better in the general population, 40% get better in those that are on dialysis. Sertraline was a bit more effective than behavioral therapy, but then there was a higher incidence of adverse effects with sertraline. There were side effects with the drug. Most of them were mild to moderate, and they consisted of like nausea or palpitations or tremor. Those are the most common side effects that people had. So the other lessons that we take away from this study is that many people that had high scores on the screening instruments do not have depression. And this is to do with the overlap in symptoms of depression with that of kidney failure. We found that a lot of people were getting treatment for depression, but the doses of the medicines they were being given were not high enough for them to work. Put differently, seems like physicians were scared of side effects and gave doses that were low. It may have prevented side effects, but they were not expected to get better because the doses were not high enough. A lot of people still feel there's a stigma with the diagnosis of depression and do not like to be given a label of depression. Both medication and CBT work similarly, with medications slightly better, but with more side effects. And so my takeaway from our study is that patients should be treated based on what's available, how much it may cost a patient, and what they prefer. To round up what I've said in the last 45 minutes or so is that at any point in time, 1 out of every 3 person on dialysis has depression. It does not just go away, and it makes it even more difficult for patients to do what they need to do to take care of themselves. In addition to suffering from symptoms themselves, it worsens overall health. Both behavioral therapy and medicines improve symptoms of depression in people on dialysis, and people can choose either of the two based on their choice, what's available, and what the cost of treatment would be. That's all I have. May, on to you and how you want to handle the questions.
Dr. Mehrotra, thank you so much for a very interesting and really important webinar. We have several questions. Shall I read them out loud and then you can answer them?
There are questions
in the time we have remaining?
The questions,
you see them?
I see them and I can read them.
And we will take it up close till 1 minute or 2 before 4 o'clock, and then I'll say 1 or 2 things about the evaluation form. So please go ahead and answer as many questions as we have time for. Thank you.
Okay. So the question is, what is the percentage for the general population? So the question, of course, is that we have said that 1 out of 3 people that is on dialysis at any point has depression. In the general population, it's about 8%. So the prevalence of depression is 4 times more common in people on dialysis than in the general population. The second question is, at what time is depression most prevalent after dialysis for ESRD? After 6 months, a year? Unfortunately, that's not very well studied. So there are not studies that are good enough for me to say that. It makes a lot of sense that people that are transitioning to dialysis are more likely to have depression, but I could not say that there are studies that have looked at that. Does depression go away after a kidney transplant? So I have 2 things that I would like to say in response to that. The first is that the prevalence of depression in people that have a transplant is much lower than in people that are undergoing dialysis. The second point is I would be very reluctant to give somebody who's actively depressed a kidney transplant, because it is essentially a high probability that they would not take care of the transplant. It is not the function of having a kidney that will make the transplant go away. So the depression would need to be treated for itself, and that they should not be depressed when they get a kidney transplant. Not sure I understand this question, what certification? You know, I suppose the question refers to what certification to give cognitive behavioral therapy. Um, uh, so it is, the best I can say is that people that are masters in social work, that training includes training to deliver behavioral interventions, and that is enough. The important thing about the behavioral intervention is to understand a lot of these issues of certification are important if there's going to be billing for that service. And so, because this is a question that we addressed in our study, is that, oh, can a therapist come to a dialysis unit to do therapy? And the short answer is, as long as they're not billing for that service, yes, that service could be provided. So if there's a member of the nephrology care team, say a social worker, who is delivering behavioral therapy, and they're salary employees of the dialysis unit, and they will not submit a bill for that service, no, their qualification of being a social worker in the unit is sufficient for them to deliver therapy. And it's usually the social workers that do give the therapy in dialysis units. I know a lot of people on dialysis deny depression even though they act angry or have the signs and symptoms of depression. How do you believe to go forth? With extreme care. I mean, people have done, I didn't have the time to share with you. In our study, we had two goals. The first goal, which I've shared with you, was to compare the efficacy of behavioral therapy with drug therapy. The second goal was to see whether we could increase the acceptance of treatment for depression by a form of motivational interviewing that we said was engagement interview. Essentially, what engagement interview entails is it takes a lot of time. It requires people to acknowledge their symptoms, that yes, you're feeling, your mood is low. Oh yes, you're not eating so well. Oh yes, you're not sleeping so well. Then link it back to potentially a mood disorder, and then engage them in indicating that there are treatments for that, and the symptoms that you're feeling could go away if you were to engage in treatment. And so it is a form of motivational interviewing that allows people to first identify that their symptoms are from a disease, and these symptoms are important for them and they want them to go away. And the way for them to go away would be for them to give a trial of treatment. And we were successful in being able to do that with people. Were these patients given weekly therapy CBT in your study? Yes. So we had 10 sessions over 12 weeks. And so for the first 8 weeks, we had sessions once a week. And then for the last 4 weeks, it was one every other week, for a total of 10 sessions. Is anxiety as prevalent as depression in dialysis patients? The answer to that is yes. Anxiety may actually be more prevalent than depression. Something like 35 to 40% of people at any time have anxiety. There is no, it is not as well studied as depression, and there is actually no study that has looked at what treatments may be effective for anxiety. The next is, would you recommend having a patient connected with a therapist once they have a diagnosis of ESRD to address this life change before depression starts? I think that's an intriguing idea. I would do it on an individual basis. There are people that would be comfortable with that idea, and there are others that will not be. So I think it's a good idea to bring it up to people, and before pursuing that further. I think it's a great idea. How do you get a therapist to come to your clinic? Now, in our study, it was as a part of the research study. So the therapist was paid for by the research study. And that is how they came to the clinic. The question is real, is that in the real world, outside of a research study, how do we implement what we learned in our study? I think there are 2 or 3 ways forward. One is to assess the work. I think the people that are most qualified to deliver behavioral intervention in people on dialysis are the social workers. The biggest challenge is the patient load that a social worker carries. And I think those are conversations to be had a unit at a time in terms of prioritizing the workload for social workers. There's hope that there are people that are advocating for Medicare approved therapy to be delivered by telehealth to be reimbursable for people that are on dialysis. That of course has not been approved, but let's say it is reimbursable, then people could use telehealth to meet with a therapist rather than go to a therapist someplace. All right.
Dr. Mehrotra, I am
Yep.
sorry to interrupt. I know we have a few more questions, but I also know that people have to get back to work and they have other things. I'd really like to keep this within 1 hour. Maybe you can answer these questions, the few remaining ones, and we can just send out the answers to everybody at a little bit of a later date. Right now, I would, again, thank you so much for this very, very important and very interesting webinar. You can tell by all of the questions and the chatting and the comments that people have had during this presentation. Right now, when you exit the webinar, you'll need to click on a continue button that will take you to an evaluation form. To receive your CE credit and also to provide us with some valuable information for future webinars, we'd appreciate it if you could please complete the short evaluation form right now. We'll be in touch for future webinars. Again, thank you so much, and I hope everybody has a wonderful day.